So upon our conclusion, as we noted, mobility seemed to rack up a little bit higher here as there was some significant restrictions in single plane movements. And with, like I said, relay cognition beliefs is really going to be more about educating regarding activity modification, as well as tendinopathies tend to have a significantly longer healing process, so kind of giving them some prognosis in terms of how this recovery may look. And then ultimately, there is an underlying motor control component that does need to be addressed, looking at a little bit of that proximal hip weakness, that may be due to inhibition, due to the Achilles pain, or that may be possibly an element that may have brought on the increased load to that Achilles tendon. The other part of prognosis, since he's had a previous episode, he has an acute on chronic type of episode where he may have some degenerative, so we call kind of some tendon disrepair within a degenerative tendon, and that's something we'll be mindful of because that will also kind of prolong that prognosis and typically does increase our volume of visits a little bit. And so for treatment today, what we will be looking at is first, I think it's still treat prior to referral. As I'd mentioned, the education is the activity modification. I do like to utilize Elasticon with plantar flexion tape. What this does, it does kind of assist that push off like with normal activities of walking. So unless you stick him in a wheelchair, he's going to be on his feet every day doing those normal activities. We know that taking the load, however, completely away does not help tendinopathy. So he does need some load. We need to reduce the load so that the tissues can heal at an appropriate rate. For the manual interventions, I would look at doing some dry needling to the medial lateral gastroc, as well as some instrumented soft tissue mobilization in this region, and then even some lateral glides to assist with that mobility restriction into eversion. Give him some passive gastroc soleus stretch, and then work in a little bit of short foot exercise to assist with kind of getting those that kind of forefoot, how it wanted to kind of pronate, try to get some support there. So maybe that helps kind of control that foot and balance and take some stress away from the Achilles. And then eventually work into some ankle plantar flexion and inversion isometrics at this time, where they can control the resistance within, a slightly irritable level, but not to the point where symptoms are completely aggravated. So they put pressure into it, they sense it, and then again, they don't have any significant lasting symptoms after it. Instead of jumping right into eccentrics where they have a little bit less control, we start with more multi-angle isometrics. So at the end of the first day session, after kind of dry needling, ankle range of motion improved from 3 degrees to that 10 degrees. He did wear the tape for 3 days, and then worked on self-stretching, and then also those isometrics 3 to 5 times a day for 10 bouts of 10 seconds each.